So let's understand this. What's the answer for this? Which of the following is true with regard to type 1 diabetes? Okay, there are two types: insulin dependent, which is type 1, and insulin independent. Okay, so type 1 is insulin dependent diabetes mellitus, IDDM. The other one is non-insulin dependent. So what is the answer for this? It's an autoimmune. Is it type 1? Is it non-insulin dependent? No, it is insulin dependent. That I've already said. Okay. Okay. And it is not associated with thyroid disorder. Is it correct? Insulin resistance is a hallmark. So what is the answer for this? So we're saying A is autoimmune. Exactly, that is the answer. Okay, it is non-insulin dependent. No, it is insulin dependent. Type 1 is insulin dependent, which is the one. I'll give you clear differences, the chart and all later on. Let's understand the concept or questions here. Okay, it's insulin dependent. It is not associated with, in fact, please understand that many of the insulin dependent diabetes mellitus, which is an autoimmune disorder, is associated with other autoimmune disorders like thyroid disease. One of the autoimmune thyroid disease is Graves' disease. Okay, because it's autoimmune, it can be associated with other autoimmune. Insulin resistance is the hallmark. No, please understand, insulin resistance is associated with type 2. Okay, and it is non-insulin dependent diabetes mellitus. So type 1 is autoimmune. That's the key. Okay, forget about all this. Okay, now which I'll give you the types and differences and everything. Don't worry. Okay, which type? So we said type 1 is insulin dependent and which is autoimmune. Now the next question is, which type of diabetes is HLA associated? What is HLA? Human leukocyte antigen. This is something which you learn more in detail about it in microbiology. Human leukocyte antigen and all, which is definitely an area on your chromosome, okay, which is associated with various diseases, especially autoimmune diseases. Now the answer is very clear. The moment I said autoimmune disease, HLA associated is going to be, what is the answer? Type 1, exactly. Okay, type 1 is autoimmune and therefore it is HLA associated. Now, a little bit more if I want to tell you which HLA. Okay, it is basically different class of HLA is there. I'm not going into details there. HLA class 1, class 2, class 3 and all. HLA class 2, please note this. Okay, HLA class 2 alleles or genes areas. Okay, and which are they? HLA class 2. HLA, just specific, HLA DR3 and HLA DR4. Remember HLA Dr. 3 and Dr. 4. Okay, so that is type 1 is associated with HLA class 2 or 2. Okay, 1 is associated with 2, which is DR3 and DR4. Okay, now again, what's the next question? Major susceptible gene for type 1 diabetes mellitus is located on which chromosome? Now, basically, we said there's a chromosome. Definitely, there is going to be an area there, which is gene, which is associated with this HLA. Okay, DR2, DR3, the specific area in the gene. So, which is this chromosome they're talking about? It's a question. Okay, major susceptible gene for type 1 diabetes mellitus is on which chromosome? What's the answer? 14620. What's the answer? Any guess? Any guessworks? Dr. Mohavish, very good. Are you solving Mudit Khanna, right? Okay, this is medical question. Anyway, okay, majorly I'm discussing, I'm going a little deeper for you to understand this part very clearly. Okay, C is the answer exactly, Mohavish. Good. Basically, it's a chromosome number 6. So this is what I was talking about. This is the chromosome number 6. And this is a short arm. So there's a short arm and long arm. And in this, there's a specific gene area which is associated with this HLA. Okay, understood? All of you? So basically, now people with what they're saying is people with this HLA, the one I said you, okay, the people with this HLA has got a genetic susceptibility, HLA-DR3 and DR4 has got a genetic susceptibility, please understand this, genetic susceptibility where antibodies are produced against which cells of pancreas, beta cells of pancreas. So beta cells are the cells which produce the insulin. So those people with this particular HLA problem or HLA allele, okay, allele is a two alleles are there for a gene, isn't it? So with this allele, with HLA DR3 and DR4, will produce autoantibodies against beta cells and it destroys. Okay, it destroys the beta cells and pancreas in the pancreas and it causes type 1 diabetes mellitus. The next question is concordance of type 1 diabetes mellitus in identical twins is ranges between what is the answer? Mahesh is saying A, Sri Lakshmi is saying C. Okay. What about others? Where are you all? Parvati is saying B. So the answer is basically C. Just know this. Okay. It is basically 30 to 70. In fact, please note, it is 40 to 60, which is the exact figure. Okay, the exact figure of concordance. Okay. The meaning of concordance is the consistency of development of the disease. Okay, how strongly is it associated with, in identical twins? For example, one identical twin has it. What is the possibility of the other identical twin having it? Okay, means what they're talking about is genetics. Okay, if one identical twin has it, what is the possibility of the other identical twins having it, which is 40 to 60%. Now, here you can't see 40 to 60, so the best answer is 30 to 70. Okay, now what does it mean? 40 to 60%, there is a possibility of genetics being involved. What does it mean? Okay, for example, if you just take the average of it, it is 50%. So 50% it is genetics and a 50% chance roll of something else. Now, what is that something else? What did we say recently? 50% possibility that the identical twin is to have it, or means to say that genetics is involved. Means to say that the remaining 50% the cause is something else. What is that something else? Focus. What is that something else we just said? 50% genetics. What is that something else? Okay, that is autoimmune. Okay, yes, Mahavish, very good. Autoimmune, the reason being autoimmune is very high now, means to say. Okay, so genetics is less, less significant when it comes to type 1 in comparison with type 2. Now, there is the next question. What is the percentage of concordance of type 2 diabetes mellitus in identical? It is definitely going to be, okay, sorry. Definitely going to be higher. How much is that? Who's the higher option here? 40 to 60, higher than that? Not 50 to 70, it is 70 to 90. Okay, 70 to 90%. Yeah, exactly, Parvati. 70 to 90% cases, it is genetics involvement. Okay, concordance with the identical twins. So, means to say that 10 to 20% is something else. What is that possibility? So 70 to 90%, I would say 10 to 30%. 70 to 90 matlab 10 to 30%, or you can call it as 20%. 20% is something else. What is that? Definitely your lifestyle, your environment, your diet. Okay. So Genetics has got a very high role to play, 70, between 70 and 90%. If an identical twin have it. Okay, now if an identical twin have it, it is 70 to 90. Okay, genetics for type 2. Now, risk of developing, if both the parents have it, type 2, what is the answer? That was identical twins. Now, both the parents have it, what is the uh, risk of development of diabetes mellitus in these patients? Okay, it is very high. Now, see, you can go for a guesswork. It is very high, 40 percentage. Okay, 40 percentage for type 2 diabetes mellitus, which is very, very high. Now, okay, in type 2 diabetes mellitus, increased fasting plasma glucose is predominantly due to. Now, here you have to understand a concept. What is that? Now you're coming into more into details about type 2 diabetes mellitus. You have got fasting blood glucose, FBS, and the other is postprandial blood sugar, PPBS, FBS and PPBS. Now they're saying that in type 2 diabetes mellitus, when a patient gets up in the morning, he has got a higher FBS because of what? Is it because increase release of glucose from the liver, that is called increased hepatic glucose output, decreased peripheral utilization of glucose, increased glucagon, decreased somatostatin? No, these two options you can simply just eliminate because the problem is associated with insulin. Okay, isn't it? Here the problem is insulin, not glucagon, nor is it somatostatin. This is how you eliminate. Okay, this is how you eliminate. It is not B, in decreased peripheral utilization. Now I'll tell you why exactly. Okay, what is the reason? So as I've told you, both of them, see, both of them increase. So two possibilities. Now, what is the problem associated with type 2 diabetes mellitus? We said type 1 is autoimmune. What is the problem associated with type 2? It is basically insulin. What is the term? Resistance. Now, please note, in type 1, the problem is there is very little or no insulin. In type 2, insulin is there. Please understand this. Insulin is there, but the body is resistant to that insulin produced by the human body. Okay, the body is resistant to that. Now, for example, you have got a piece of muscle there, just okay, an example. You have got a piece of muscle there, which is utilizing the glucose. Okay, which is utilizing glucose. What body does is it produces, for example, just for your easy understanding, it causes a coating, for example, outside. Okay, so that this insulin cannot act on the muscle and it cannot utilize the glucose. That is called insulin resistance. So insulin is there. In fact, insulin is very high initially. You'll see that. But then it cannot utilize this insulin. Now you'll ask me, but then the treatment, many patients are treated with insulin. Now that is, what is that? That is not human, I would say that is not the insulin produced by that person's body. No, this person's body is resistant to his insulin, not from the outside. So his body is acting for that. But here, his own body's insulin is resistant. Okay, so now the problem, one problem is decreased utilization by the tissues. For example, decreased utilization majorly, as I've told you, by the muscles and even fat and liver, which are the major like organs which utilizes glucose. Due to this insulin resistance, this problem occurs. Okay, now as a result, PPBS increases. Please note this. Okay, due to decreased utilization, peripheral utilization of glucose, what happens is PPBS increases. What is PPBS? Postprandial. Means what? A patient is having some food, carbohydrate food, his body is not able to utilize it. After food, it will increase. Postprandial will increase, isn't it? Now, on the other side, if the liver releases glucose, okay, if the liver, okay, for example, this is a liver, just imagine, okay, this releases glucose. How does the liver releases glucose? What's the mechanism? What's the process happening in the liver which helps it to release glucose? What are the two biochemistry? What is it? Anyone? Okay, it is glycogenolysis and gluconeogenesis. It will release, yes, gluconeogenesis, Mahavesh, very good. Okay, so as a result, the person gets wake up in the morning and you'll see that the fasting blood glucose is high because lots of glucose has been released from the liver. Okay, so the question is in type 2 diabetes, increased fasting plasma glucose is due to increased hepatic glucose output. Now, if the question is increase PPBS, is option B, decrease peripheral utilization. So this particular question, the answer is answer A. Understood all of you? Any doubt you can ask. Now we said about glucose resistance. So both of these are, so please note, both of these are mechanisms of insulin resistance. Okay, whether it's the decreased utilization or increase this thing. Okay, see basically what happens in the hepatic output of more glucose is that glucose is not, sorry, the liver is not able to sense that already there is enough glucose in the blood. That's another problem associated with insulin resistance. Okay, and it is very much reversible. Please understand that. Okay, it is reversible. Type 2 is reversible. Insulin resistance is reversible, whereas autoimmune is not. So we say that there is glucose intolerance, or I would say insulin resistance. Okay, both same. Insulin resistance is due to deficiency of one particular element or mineral is associated with this insulin resistance. What is that? Basically, it's very much utilized in the treatment, especially the, the Ayurveda treatment and all. They put this chromium in the medications and they just give it to the patients. Okay, and many patients develop insulin resistance due to deficiency of this particular mineral. What is that? Anyone? Answer is chromium. Okay, the answer is chromium. Please understand that. So chromium can cause deficiency. Basically, it's all interaction between, as I've told you, interaction between the, for example, this is a tissue. Okay, on surface of this is receptors for insulin. Okay, and you have got insulin coming from here. Okay, I'll just put it as I. So this interaction is increased by chromium. Okay, this interaction is increased by the chromium, and that's why basically it's a kind of reversal of insulin resistance, you can call it to some extent. Okay, now let's come to this particular question. Let's see what is happening here. A 65-year-old woman visited her physician, complains of increased thirst, urination. Now see, imagine you are doing with a question which is new. Okay, now you know that we are discussing diabetes. Okay, increased thirst and urination. She also felt fatigued and diminished urine output. Okay, fatigued urine output diminished. She had numbness of fingers and palpable ulcers on her soles and feet. See, please understand that this is not going to give you anything. Don't say that, what is the answer? What is the answer? Don't search for the answer now. Wait. Her lab findings of oral glucose tolerance test. Now, this typically says that it is something related to what? Diabetes. No, you might see that, okay, so what about the increased thirst and urination and all those things? It can also happen in other diseases, including diabetes insipidus. Now, the moment they say that oral glucose tolerance test, which is FBS is 115, in fact, okay, I would say it's not very high. 1 hour, that is high, 270. Okay, and 2 hour, it is 205. So it's coming down, but still it is very high. Now, urine glucose is very high, plus. But now they're saying that there is no ketone bodies. Okay, no ketone bodies, which of a statement is correct? Now, read the options. So give some moment. wait and read the options. She's suffering from insulin dependent. She's suffering from non-insulin dependent. She's suffering from type 2. She was treated with oral. So basically, all these three options are telling you, this is how you have to analyze the question. All these three options are telling you that they're asking the difference between type 1 and type 2. And what are the major difference in the questions you're going to get to differentiate between, I'll give you the differences I told you, but the major differentiating factors in the questions you're going to get to differentiate between the two is majorly, please note, it is your ketone bodies. And please note, there's something known as, we'll come to that, there is something known as diabetic ketoacidosis, which is there or which is more common in type 1 and less common in type 2, diabetes ketosis. So the moment they say that it is negative, it is not type 1, means to say it is type 2. Okay, now let's analyze. She was suffering from insulin dependent. No, insulin dependence type 1. The question is, which of the following statements not correct? Okay, not correct. So this is not correct. Let's see the next option. She was suffering from non-insulin dependent. Exactly. She's suffering from type 2. Exactly. She can be treated with oral hypoglycemics because it is type 2. Type 2, you start with oral hypoglycemics. Later on, what happens is insulin naturally goes down. Okay. So then you have to go for insulin itself. So the answer for this is A. So this is how you analyze and answer the question. Okay, don't jump to an answer saying that, or don't jump to a conclusion that I don't know this. Don't make such mistakes. Okay, don't jump to any conclusion that I don't know this. No, you have to know this. Okay, you have to know this. Now, hope you got this. Okay, majorly, I'll give you the chart of difference, everything, but majorly type 1, type 2, the major differentiating factor is diabetes ketoacidosis is seen in type 1, not seen in type 2. Now, why is it seen in type 1? I'll just give you this thing. In type 1, what is happening? Very little insulin. Okay, or I would say there is no insulin because the beta cells are destroyed. Okay, now, why do you want insulin? Insulin is used to utilize glucose, isn't it? Utilize glucose. So now, in a patient with type 1 diabetes mellitus, there is no insulin for utilizing glucose. So what is happening? The body cannot utilize glucose. So what will it do? It needs energy. Anyway, it needs energy. Am I right? So instead of utilizing glucose, it will start utilizing fats. And the byproduct of fat metabolism is ketone bodies. Okay, the ketone bodies, and this ketone bodies increases. So it is called diabetic keto. Now, ketones are acidic. Okay, ketones are acidic. We'll come to that. So we'll get diabetic ketoacidosis. Now, what happens in type 2? Though the insulin resistance is there, it is not absolute resistance. Still, body is able to utilize some glucose for energy. So it doesn't need to depend on your fat unless what happens? Your insulin level has completely drastically come down. Okay, please note this. So now, in a patient with non-insulin dependent, so what is non-insulin dependent? Type 2. Non-insulin dependent diabetes mellitus, which are the following conditions seen? Ketosis commonly occurs on stopping treatment. Is that correct? Which is the following condition is seen? Ketosis doesn't occur on stopping treatment because still the body can utilize. Yeah, it is wrong. Mahesh. Ketosis doesn't occur commonly after treatment. Hypertriglyceridemia never occurs. In fact, it occurs. Okay, hypertriglyceridemia is one of the major complications, or one of the major, not complications, one of the associated factors. We come to that with type 2 diabetes mellitus, and this leads to cardiovascular problems. Okay, which basically triglycerides increase. Okay, triglycerides increase in type 2 diabetes. Pancreatic beta cells stop producing insulin. That is what you call it as type 1. Okay, not type 2. Increased levels of insulin in the blood may be seen, which is the answer. Now, I should have asked this question to you. Now, you know this. Basically, in type 2, as I've told you, it is basically the resistance. Okay, it is basically the resistance which is the problem, not the insulin deficiency, at least initially, in the initial stages. Okay, insulin is there, but it is not effective. So what the body does, body feels that, body doesn't know that there is some resistance. Okay, body feels that there is doesn't know that it has got some resistance. It keeps on producing insulin. So in the blood, insulin levels are very high in type 2 diabetes, but it is resistant or it is not effective. But then later on, what happens in type 2 diabetes? Yes, Sri Lakshmi, very good. It's D. D is the answer. So later on, what happens? The body resistance continues. Lots of insulin produced, and slowly by slowly, pancreatic cells also feel tired. They say, okay, I'm going to stop producing insulin. So beta cell function declines. So the answer is D. Okay, so many pages. In diabetes, all of the following statements are correct, except. Good to have some pages if at all needed, isn't it? In diabetes, all of the following statements are correct, except. What's the answer? Patients with type 2 diabetes never require insulin. So what I'm saying, all are correct except. So which are correct? Patients with type 2 diabetes never require insulin. Is it correct or wrong? Correct or wrong? Majority of type 2 diabetes patients die from cardiovascular. Yes, cardiovascular disease is one of the biggest risk factors for type 2 diabetes. Majority, yeah. Type 2 diabetes never require insulin is a wrong statement. Initially, they don't require. You know, some of your family members will be. Initially, they don't require because it is insulin resistance. You reverse the resistance. But later on, as I've told you, the function of beta cells come down, you require insulin. Majority of type 2 diabetes patients die from cardiovascular. Exactly, yes. It is one of the biggest risk factors. Okay, one of the biggest risk factors. Weight loss is common symptom in type 1 diabetes. Yes. Why? We said diabetes, what is the reason behind diabetic ketoacidosis? Utilization of fat. Okay, the fat comes down. Decay is less common in type 2. So weight loss is less common. I'm not saying it is not there. Recognized endocrine causes of diabetes include acromegaly and Cushing syndrome. Now, what does that have association? Is it correct or not? Recognize endocrine causes. Definitely. Patients with endocrine diseases also can have diabetes. And I'm going to give you a shocking revelation now, which you might have never heard. And even it's a little controversial, but definitely it's a reality. Basically, acromegaly. What's the problem there? Acromegaly is increased growth hormone. Okay. What is the problem associated with Cushing syndrome? Increased cortisol. Please note. Both increased cortisol and growth hormone can cause insulin resistance, or means to say that it decreases the action of insulin on the tissues. It can cause insulin resistance, both of it. So it is association. Now, what did I say? That shocking revelation. You know, one of the reason to increase your growth hormone, or one of the way you can increase your growth hormone secretion is what? It is exercise. Now, I can say you little, I can sound a little controversial, but this is a reality. Excessive exercise, not normal exercise. Basically, normal exercise, sufficient exercise, it is going to be beneficial definitely by increasing the sensitivity of insulin tissues, because muscles utilize. Muscles is the biggest tissue which is utilizing your glucose. So muscles can, you know, increase utilization of glucose, so its sensitivity increases. But excessive exercise, some people we see, you know, morning, evening, night, or morning, evening exercise, or every day, lots of exercise, don't do that. If your growth hormones continuously get increased, you start developing insulin resistance. Okay, too much of exercise is also not good. That is what I mean to say here. Okay, now next question. Did I mention anything? No. Okay, now I'm going to give you the comparison. 29 after this. A 29-year-old person is non-diabetic on oral hypoglycemic. He has lost weight and never had decay. Oh, wow. This is something serious, isn't it? Lost weight. What does it indicate to you? Type 1 possibility, isn't it? But never had decay, not type 1. Okay, not type 1. Which is his grandfather is diabetic, but his father is not diabetic. But then he became. So grandfather is diabetic, father is not diabetic, he is diabetic, never had ketoacidosis. So now I told you he has lost weight. But as I've told you, type 1 loses weight. Type 2, it is not that he'll never lose weight. The moment his body's insulin secretion comes down, he can utilize, he starts utilizing fat. It can lose weight. But then more importantly, never had decay. Never had decay means it is not one. At least one's possibility that he can develop a decay. So never had decay very clearly says that it is type 2. Now, what is the problem here? What do you find something odd? Did you find anything odd here? Anyone? Anything odd inheritance pattern you saw? Something the questioner wants to point out towards something very specific. That's why he's saying his grandfather is diabetic. So why do you want to say about grandfather? That is what my question is. Okay, grandfather is diabetic, father is not diabetic. I'll tell you, I'll give you another question. Similar question. A 29-year-old person is a non-diabetic on oral hypoglycemic since 3 years. He lost weight, never had decay. Now, this is important. His grandfather and father both are diabetic. Now, here we're talking about inheritance pattern. Very important. Okay. Now, the moment you say there is never had decay, it should signal towards type 2. But please note one more possibility where you don't have decay. Please note this. Two possibilities are there where you don't get decay. Okay. One is type 2. Second is MODY. MODY. It's not the other Modi Prime Minister. MODI. This is MODY. What is MODY? Maturity onset diabetes of young. So those are two possibilities where you don't get decay. Type 1 is decay. But now, how do you differentiate between these two, type 2 and MODY? Okay, MODY. I'll say it as MODY. So, how do you differentiate between these two? That is what the inheritance pattern. Okay, now what they're saying is in MODY, there is something known as vertical transmission. Please note, vertical transmission, where at least two successive generations should have it before the person who's in the picture have it. Okay, at least two successive means what? The grandfather should have it, the father should have it, and the third one, that is the person in picture, should have it. So this is two. And ideally they say three. Means great grandfather have it, grandfather. That's not easy, but then that is ideal. Okay, so two successive generation have it. So here, how many generations have it? In this question, his grandfather and father both are diabetic. How many people have it? How many generations have it? So easy, just type. Come on. No, it's your time you're losing. Okay, the quicker you answer it. No, my question is not A or B. How many generations have it in this question, in this particular thing? Exactly, so easy. Not three, not three, Parvati, it's two. Grandfather and father. Now the person who's having it is definitely there. Okay, the grandfather, father is having it, and that's this person is having it. So two successive. Okay, two successive people. Now, in this particular question, how many? Is there any successive? No, grandfather is having it, but father is not having it. Then grandson is having it. So this is type 2 diabetes. As I've told you, DK, never had DK is pointing towards type 2 or MODI. So now MODI is two successive. Here there is no two successive, so the answer is type 2. Understood, all of you? This very important question, which has never asked for you, but no, these are all medical questions. Okay, I've just included this so that you have this. Okay, now we'll see a comparison chart very soon. What's your answer for this? All of the following statements about maturity onset, this is MODI, onset diabetes of young, MODI are true except age less than, so it is maturity onset less than 25 is a typical age, okay, of MODI. Beta cell dysfunction, so yes, we said type 1 is autoimmune, type 2 is insulin resistance. This is MODI, which is beta cells doesn't function. Beta cell dysfunction. Basically, so try to differentiate between type 1 and type 2 in this area, pathophysiology. Type 1 is autoimmune destruction. See, it is like a building is being destroyed by a bomb, which is type 1, and MODI is a building which has simply fallen without any specific cause, you can call it. So the first one is basically destruction. This is the third one is, or the MODI is dysfunction. Please note that difference. Response to sulfonylureas, yeah, very, very important. So basically, in MODI, you have got very little insulin. Okay, insulin is very low, like your type 1. In type 2, you have insulin. Okay, but then it is dysfunction. The function is affected. So what sulfonylureas can do is increase the insulin secretion by the beta cells. Okay, one of the mechanisms by which sulfonylureas act is increase the insulin production from the beta cells, because it is not functioning properly. It can cause insulin dependent. No, it is not still insulin dependent. It is non-insulin dependent. Please understand. It is dysfunctioning, but still you can treat it with sulfonylureas because it is dysfunctioning. It is not destruction. The beta cells are still there. It can still function, but due to some cause, okay, or I would say it's an autosomal recessive disorder. I think we'll come to that. Due to this genetics from that is the vertical transmission, his beta cells has been dysfunctioning. So you give sulfonylureas, it can act. And so there is not a insulin dependent. Okay, it is not insulin dependent. Did I miss anything? I'll come to the description of this. Okay. Yeah. Yeah. Okay. Hope all of you can see this picture properly, visualize. If you want to, you can zoom this. Okay. Okay, there's a zoom option there. So this is the answer exactly. Okay, I'm going a little because many concepts. So we're going to make a differentiation. Okay, which you know, which I've discussed, but then again, I'll just give you a understanding. Now, basically, type 1 diabetes mellitus, you can visualize it, isn't it? All of you are able to visualize this. Yes or no? So type 1 diabetes is basically childhood disease. You can get in the young adulthood, but majorly childhood because it's an autoimmune, very young. Type 2 after 40 years. And please note, MODI is less than 25. There can be variations, I'm sorry. There can be variations, but then this age group is very important for you to differentiate. Okay. Now, please note, family history is very common in type 2, and it is very strong inheritance, monogenic Mendelian, one gene involvement. Okay, one gene is influenced. Whereas I think type 2 is polygenic. Okay, I have to confirm that, but then yes. Monogenic, autosomal dominant. Okay, this is important. And as I've told you, vertical transmission, 2 successive, ideally 3. Okay, and as I've told you, as you have seen, type 1, it is less common. Family history. Okay, the identical twins and all we said, isn't it? Now, when it comes to your risk of ketoacidosis, definitely insulin is very, very, very low in type 1. So it's ketoacidosis is very high because fats utilized. Low, it is low, except in stress Medicare, whatever. Very low. Now, here again, the problem is there is dysfunction. There is no absence. You still have some insulin to work out with. Okay, this Modi people, Modi disease, not the Modi people, rather Modi disease people, they still have some insulin. They have that, high blood sugar level, but not to the level of type 2 or type 1. So again, they have insulin enough, so there is low. So this is, as I've told you, this is something which is common for both, isn't it? I've told you. But now the major difference is, one is this age group, as I've told you, and definitely this 2 successive generation. We saw it, isn't it? Now, next. Insulin dependence, definitely. Naturally, the first one is insulin dependent. The other 2 is not insulin dependent. We know it. Obesity, now, this is very, very important. Okay, obesity is very commonly associated. You might have seen type 2 diabetes commonly associated with obesity, and definitely with the moment obesity is there, cardiovascular. The other 2 is not associated. Okay, and more importantly, as I've told you, this one you have got weight loss. Here also you see some weight loss. Okay, but this is more commonly associated with obesity. Okay, now pathophysiology, autoimmune, as I told you, insulin resistance, dysfunction. Okay, beta cell dysfunction, genetic defect. Now, one more thing I just want to add here is your insulin and C-peptide. What is C-peptide? Okay, it is something, I think it is combination peptide or something. You don't need to learn the name and all, but it is C-peptide. Now, C-peptide is a peptide, okay, which is released along with insulin from the beta cells. Beta cells release 2 things, just know it, C-peptide and insulin. Now, the problem with insulin is it has got a shorter half-life. C-peptide has got a longer half-life. So now, as I've told you, if both of them are released together, and insulin, just imagine this is insulin, and this is gone because of shorter half-life, this is still remaining. This will tell you that how much insulin was released. Am I right? Because both are released together from the same source in the same amount. In the same amount, please note, same amount. So now, if this is gone due to shorter half-life, this will tell you that how much insulin was there. Now, if, for example, no C-peptide is there, what does it mean? No insulin was there. Okay, so this is important. Lower absent. In type 1, no insulin. Lower absent, there is no insulin. In type 2, we said it is basically insulin resistance. Insulin is there. So, though insulin is gone, C-peptide will be high. Okay, usually high. This again, dysfunction. It is not that it is absent in Modi. It is still there, but low again. Okay, so please note, both of this is low. Okay, and whereas this is high. Understandably, it is all about resistance. Understood? All of you? I wanted to finish this also, but we'll do descending problems and the complications in the next class. I guess. How much more? Is it? We'll make it less stress. Learn this, and what we have is DKA. Presenting problems, enough is there. A lot is there. Anyway, we won't be able to finish them up. Okay, there is DK and HS is one of the biggest presenting problems. Don't worry about the slides there, okay? Questions only. The slides are too much space being left. We'll do it in the next class tomorrow. And we'll finish this by tomorrow. Okay. We also have to discuss a little bit on complications also. Not much complications, but presenting problems and complications are related only. DK is, you can call it as a complication, you can call it as this thing also. Who all was there?